Let's proceed to perform extension local gliding mobilization to L3, L4, in this case on the right side. In order to do this, we need to first pre-position the patient's segments to appropriately lock them and avoid pain. The first prepositioning we need to attend to is what we do with L4-5 and below. L4-5 is the pain-generating segment, and it's uncomfortable in extension. So let's flex L4-5 and L5-S1. I'll place my middle finger of my cranial hand in the L3-4 interspinous space, my index finger of my cranial hand in the L4-5 interspinous space. I'll then reach down and through the legs, I'll bring the knees up closer to the patient's shoulder and flex at L4-5 and stop before the patient has flexion at L3, L4. Next, I'm going to extend through L3, L4 from cranial down. So I'll place my middle finger in L4, L5 and my index finger of my caudal hand in L3, L4. Reaching under the patient using her elbow of her left arm, I'm going to extend her segment through L3, L4, not allowing extension in L4, L5. If I want to make sure that I don't have extension L4, L5, I can go back and repeat what I did earlier to L4, 5 and L5-S1. Next, I'm going to side bend at L3, 4 to the right because I need that right side bending for the mobilization. I reach to the top of the table, I raise the table up, and now she's side bent to her right at L3, L4. Now, one might ask, why are we not side bending her L2, 3 and cranial to the left? That's coming. Next, I'm going to rotate her to her left at her L2, 3 and up. So, I'll palpate the sky side of L2, 3. Here's 5, 4, 3. I go sky side L2, 3, and through her shoulder, I'm going to rotate her towards the mat. Relax for me. Rotate her down towards the mat until she rotates at L2, L3, but not L3, L4. Here's where the left side bending comes into play. At L3, 4, because it's over the hinge, she side bends up to her right. Now, by virtue of rotating the other segments, she's side bending L2, 3 and above down to the table. We have a problem though. By pulling her shoulder forward, it has removed at least part of the extension we earlier achieved at L2, 3 and L3, 4. So, I'll palpate once again L4, 5 with middle finger, L3, 4 with index finger. I'll reach under the patient and with her elbows against my hip, I'm going to extend her without the patient helping into L3, L4. Now I'm ready to produce the mobilization. To mobilize, what I'm going to do is I'm going to place, we're doing 3, 4, so here's 5, 4, 3. I'm going to take my stabilizing hand and stabilize on the sky and most importantly, cranial side of L3. My mobilizing hand simply grasps with the forearm to near the ischial tuberosity and my fingers to the iliac crest. I'm simply going to create in the mobilization a right side bending through the pelvis. I can, remember we said before, L3, 4 may couple in any given direction, so I can feel which way the segments are going to rotate, and I'll simply go on the opposite side of the spinous process, so the direction the vertebra is rotating. So the direction, I'm going to block the rotatory deviation of the spinous process. And so in her case, I'm going to drop down a little bit below or to the mat side of the cranial spinous process because I feel the spinous process rotating towards the mat here. And now I produce subtle, small, side-bending glides in the segment. What I'm doing by shifting the pelvis is moving the cranial articular process of L4 cranially on the caudal articular process of L3. Here. Make sure that the sacrum's vertical. I can use my chest to ensure that. And I mobilize her this way. I'm getting a locking in the caudal segments because she's flexed and she is side bending to her right. I get locking in L2, 3 and above because she's extended, rotated to her left, and side bent to her left. Small oscillatory movements, and then I can hold for 30 to 40 seconds. I let off. I can repeat that holding of 30 to 40 seconds, 5 to 7 reps to ensure creep deformation and unwrinkling of the collagen of the capsule. Then I can let off. I'll repeat the local traction and extension gliding on her left side by having her lie on her other side to ensure segmental extension, and then go back and retest the segmental mobility. We can choose an alternative technique whereby we can raise the patient's leg into abduction in order to accentuate the side bending movement that we want at L3, L4, thus reducing the influence of the weight of her sky side leg on the movement of the pelvis. Here I've prepositioned the patient in the same locking at L2, 3 above and L4, 5 and below. I'm blocking the cranial aspect of the L3 spinous process, and in this case I'm just using my leg to support her leg, accentuating the side bending for the mobilization that we want.